Welcome everyone to our public board meeting of the Integrated Care Board for Cornwall and the Isles of Scilly. I want to reach out to everyone and say thank you ever so much for coming to this lovely Tregenna Castle Hotel. It's one of those times where annual general meeting is an interesting day at the best of times. So we've had our private board meeting this morning. We're having now our public board meeting, and then later on in terms of the day we will move into our formalised AGM after this public board meeting, and then after the AGM, which is the formal part of it, we will move into more informal structure for what is lovingly known as our True North. I'd also like to welcome our guests who have joined us, our board members and some members of the public and colleagues who have joined us today. We're also live streaming the event, and so there are some public members viewing us today. So welcome to them. In terms of apologies, I've got the same list of apologies. So we've got Neil, Debbie, we've got Jane. Anybody else? Joe, you're standing in for Emma, and Nick, I can see on the call, is standing in for Emma Ridgewell Howard as well from the LMC. And Neil, our non-exec, is away on holiday. So that's the apologies. So can I move us on to declarations of interest? Is there anything on the agenda anyone is concerned about, want to declare anything, or you're happy to proceed? Yeah? Very good, thank you. So if I can move us to the minutes. The minutes are as written, unless there are any factual or accuracy changes people want to change. Nope. Okay, so we'll note those as agreed. Karen, can I turn to you in terms of matters arising, any outstanding action points? Is there anything that you want us to pick up?
No, thank you, Chair. Everybody can see the action grid. There are some things that are due to come in October, November, and as far out as January. And obviously, subject to a conversation we were having earlier about how the board forward view will potentially change. We will be looking at these agenda items to see how they fit in to the board as we move forward. There are some that we are recommending to close. So that is about the learning from the vignettes, because as I say, that's in November. Engagement strategy, November. There's two particular ones there about the integrated performance report. They are 2324101. And they'll be covered by the IPR item later via Kate, who will give us a verbal update around those two particular topics. But as I say, it's just to note that while in this particular action grid, they have a target date on them, that is going to be subject to change.
Okay. Are we happy with that? Very good. Okay, so let's move on to the chair's update, my report. So I'm going to take it as read, and I'm just going to sort of pull out just a couple of points. And as I go through some of this, actually, I'm going to invite Steve to make some observations as well on this. So I actually want to start in the place where I want to thank everyone for the away day that we actually had, the whole systems board with all partners attending. I think it was a great day. I think it just demonstrates yet again our constant maturing of us in terms of collaboration, challenge, not always agreeing, but actually working way through our key issues. So thank you for that. Some of that was looking at the last event to the development of our joint committees. And you can see in my note here, we've actually had some legal advice. We're going to take that legal advice, and one of the things that therefore that's meant is that while we continue to develop our proposals for joint committees, we're looking to probably the spring now to do that, is that we spoke this morning in our private session about how our board structures, both in public and private, will be going forward over the next 6 months while we wait for joint committees to be in place. And part of that means that we'll be moving to a new cycle, as you'll see in my the back of my chair's update, which is increasingly moving to a rotation in 1 month of being about in-year quality, finances, workforce, and other key agenda items, but in-year and an absolute focus on the key issues that we've got there. Much more of a deep dive and spending much more of our time focused on that. And then alternating with the following month, it'll be much more about the longer term strategic issues, particularly looking towards the sort of the golden thread between the Health and Wellbeing Board's strategy, our integrated care strategy, our joint forward plan, and also how we move from year 1 to year 2 to year 3, etc. In that journey in terms of forward planning. So I was very pleased, and thank you to board colleagues for doing that. So we will be moving to that new agenda item regime. I also just want to celebrate, if I may, the work the executive group have done for the ICB, led by Kate and Patrick, in terms of the rephasing, restructuring of the ICB, looking at our purpose and how that's going to be done. Phase 1's been done. I'm sure Kate will talk more about that as we go through. The reason why I'm touching on it is it does actually have some constitutional changes as a result of those REMCOM proposals. And we have actually gone through that this morning, and we are now putting to our region and NHSE colleagues for formal adoption of the changes that flow from that REMCOM and Phase 1 into our new constitution. The one thing I'll pick out from that is, as we increasingly have pharmacy, ophthalmology and dentistry in our bag, I've consulted with the lead chairs of the local committees of pharmacy, optometry and dentistry, and certainly looking towards joining us as and when it is appropriate, so that we get their insights that may be there, that we should be hearing more on. I think I'll leave Kate later on to talk on some of the quality and safety issues that come out of it. But I also think, just touching on the update I was going to give you in terms of the non-execs appointment, we chose actually not to appoint this time round. One of the things that is actually flowing out of some of the joint committee work and some of the new agendas and ways of working, and the speed at which we're all working together so much more collaboratively and at the pace that that's working at, which is delightful to see, is it presents the opportunities of new ways that we might think about the way in which our non-execs are working collaboratively as well. So we're going to think again on that. So I just thought I'd update you that we haven't appointed anybody. I will be speaking to Carol, and then we'll be talking to Kate and other colleagues, particularly the chairs of RCHT and CFT, Mary and Margaret, about quite what might do next. So that's my update. Is there anything that you would like to ask about, or just take that as note and we can move on? No? Thank you very much. So I think we now go to Kate, your agenda item, please.
Thank you, John. So that my update's in front of you. I have a few additions to it. So it's our annual general meeting today, so it reflects our first year really of full operation as an ICB, and a time for us to celebrate the improvements we've made, but also to reflect on the things that we still need to do. I've just received our system oversight framework letter from Elizabeth O'Mahony, our regional director, which states that we'll stay at level 3 of the, or segment 3 of the national oversight arrangements. And in particular, she's noted on how we've worked together around our system oversight meeting, and how we work together to make sure that we are doing all we can for the people that we serve. So I think that's really heartening. I just thought it was important to mention about reinforced aerated autoclave concrete, more of an issue for our providers than it is for us as an ICB. But of course, our services are absolutely dependent upon the environment in which care is provided. And we will be going through a very thorough process as an NHS over the next weeks and months to make sure that our facilities are as safe as they can be. We've submitted our pre-delegation assessment framework for specialised commissioning. It was discussed at our Finance and Performance Committee in July, and we, as with all the ICBs in the South West, are deferring delegation of specialised commissioning until 25-26, whilst we work out how we work together as a community across the South West. Because people who understand specialised commissioning will know that as an individual ICB, we probably wouldn't want to commission these services in isolation, and we would want to move to a group model of collective commissioning. System recovery remains a live topic for all of us as we work through the back end of this year and moving into what is going to be a difficult winter. We have systems and controls in place to make us effective as possible. But having said that, the amount of pressure that our provider colleagues are feeling through industrial action and just the constant level of demand that is at front doors means that we're doing this within quite a difficult context. I just move on to winter planning, and we've had a winter planning workshop, and we will be, we've submitted our first cut of the winter plan, which we will be coming back to augment. One of the things that we are very focused on is that the avoidance of admission is often better for some of our more vulnerable people, and that our winter plan this year needs to focus on the 30% of people who go to the emergency department for whom an alternative service would be better. We are tying this into the work that we're doing with Deloitte so that they can do some detailed modelling for us, that if we did X and Y, then Z would be the outcome, so that we've got some really good metrics to monitor whether we're moving together in a helpful way over winter. We've recently had a business case in from our place colleagues around the extension of the Brazilian model that's been rolled out in the mid and central part of Cornwall and the Isles of Scilly. It's the health inequalities money that we've been allocated and that we've held back until we had a scheme that looked like it would hit health inequalities and deliver a positive benefit for our population. The extension of the Brazilian model looks like it's going to do that. And I am really proud of our places that what they haven't done is said, we'd like to divide the money by 3 and it's equal shares. They've targeted it at the populations who have the greatest requirement for care in their communities. And as a maturing of that place-based model, I think it gives me even greater confidence that as we move forward, we'll be able to make better decisions for our population. And then I would just like to finish with some reflections around the outcomes from the tragic events around Lucy Letby and the crimes that were committed in the neonatal intensive care unit. It is time for us all as an NHS to think about how we work together to protect our most vulnerable, and in doing that we work together as a team. So if we come back to the conversations we're having around joint committees, closer working, the very strong signals I'm getting from our exec directors that we will work together for our population, then I just would like to take that into practical things that we're going to do over the course of the winter to make sure that morbidity and mortality are at the centre of what we do, and we use those signs and signals to provide safer services for our people. And that's it for me, John.
Thank you. Any questions? Tom.
A comment, really, not a question, is just to say that that's really good news about the soft letter, Kate, and to say that I think it's evidence of good working across the system. So thank you to the providers, to the council, to the voluntary and community sector for all showing how we are working better together. We know it's not a done deal. We know we have a lot further to go. We know we face significant challenges in Cornwall that aren't going to go away overnight, but it's really good evidence of direction of travel. So well done to everybody.
Thank you. Sure.
Yeah, sorry, just to understand what the different levels in that oversight framework would mean.
That's a really good question. So the NHS has got a national system oversight framework. So segment 1 are people hitting mainly all of their constitutional standards and are managing the quality and financial interface. And segment 4 is effectively the old special measures. So people who are struggling with both access, quality and money. And we are in segment 3, but we've got very clear exit criteria into segment 2. So winter is really important for us in terms of our system oversight framework, because maintaining the access on constitutional standards, quality and money is something we all need to work together to do, because our collective intention is to exit 23-24 in segment 2, not moving into segment 4.
Very good. Steve?
Yeah, thank you. Very positive to hear the soft 3 system outcome. Kate mentioned the Lucy Letby case and the Countess of Chester matters, and I just wanted to update board that NHS England wrote to all provider and ICB organisations, setting out 5 things for provider boards particularly to be assured of, and they are that all staff have easy access on information on how to speak up. Relevant departments, such as Human Resources Departments and Freedom to Speak Up Guardians, are aware of the National Speaking Up Support Scheme. Staff, thirdly, should be supported to speak up, particularly if they have cultural barriers or other obstacles to speaking up. Fourthly, the board should seek assurance that staff can speak up and are confident to do so, and whistleblowers are treated well. And then finally, the boards regularly report, review and act on data. So just to provide an assurance that South Western Ambulance Service, University Hospitals, Plymouth, Cornwall Partnerships, NHS Foundation Trust, Royal Cornwall Hospitals and other NHS provider organisations are directly and actively reviewing their position against each of those 5 areas, and they form part of how we would reassure our staff across the system that we're doing whatever we can to enable them to be safe and able to speak up where they need to exercise those routes.
Susan.
Thank you, Chair. On that point, we have already done a self-assessment against the 5 areas that were outlined in the letter. I've met with Kim O'Keefe and Sarah James and CFT, so we have that self-assessment and a paper that will come through our quality committees. But Steve's absolutely right, we need to spread the net wider on that, but I think it's really important that we establish where we are in the system against those 5 areas.
Very good. Okay, thank you. And so just before we move on, Nick, I don't know whether you were with us at this point in time, but because we've got the AGM today, if you notice, we haven't actually got our usual sort of video vignettes. In fact, the Brazilian model actually came from one of those video vignettes about actually having a citizen's voice in the room. I'm sure we probably would have come to the surface anyway, but it's a good example for me where actually some initiatives done at place level, routed through into the boardroom, has now been supported by the executive room, is being scaled at community and place level. So I just thought if you didn't know that, it would be helpful to see how the user's voice is actually, or the patient's voice is having an influence in what's going on.
Thank you, John. A growing trend.
Thank you, John, and thank you for the comments about how we're benchmarking and how we're assessing ourselves against the 5 points. I'm wondering whether and when we might be going to review our progress on that. So do it again and see how we're doing.
Okay, thank you very much. Did you want to answer?
In all honesty, I think this is a continuous piece of work, but we're also mindful that there's an independent inquiry. So it would be, we also will need to wait for the outputs from that as well to take the work further. But I think it's something that we should be monitoring through our quality committees very closely.
Noted. Thank you very much indeed. Okay, colleagues, let's move on, if I may. So we have a finance high-level overview, for a short 10-minute overview. Short 10-minute overview.
It'll be a very short 10 minutes overview. So let me just highlight to colleagues my very short overview of the financial position for the system. And as per highlighted in the integrated IPR report, the year-to-date position reported at month 4 shows a 4.7 million pressure off plan across the system. And of that, 2.7 million is our assessment of what the impact of strikes are for our system. So there's a national recognition of the challenge strikes are providing organisations in how we manage those. So currently we're working on the expectation that they will be managed within budget for the remainder of this year, but there's still some national clarity on how that is going to be done. We still have significant pressures, and we fundamentally are putting energies, as colleagues will know, into our cost improvement programme across the system. We have external support on that programme, and we're expecting to report in detail on that within the next 2 weeks, and it will come to the next board with clarity on delivery and also be presented through the various committees. And I wasn't going to say a lot more at this stage, but I think there's some important movements to highlight that we'll bring to the next meeting. The one other thought is we continue to have the staffing pressures in terms of costs that appear through from agency, which is a huge focus for us over the next few weeks to see some real impact on that, and that enable us to redirect resource in the areas that we would choose to redirect. So those are the things I think I'd highlight, but happy to take questions from colleagues.
Anything at this juncture? Steve?
Yeah, thank you. Really helpful update. The industrial action funding, Simon, continues to concern me. we know that we've, we know that. Yeah, thank you. The industrial action funding does concern me, and we know that systems nationally have provided funding mechanisms for the first month of industrial action in April, but currently no funding or mechanisms have been provided for the industrial action in June, July, August. We know that we're facing further significant action in September and October, and as you've outlined, that's having a material impact on our financial integrity. And I just wonder if there's anything further we can do as a board to escalate that, because clearly these issues can't be resolved by individual integrated care boards. They're national matters.
Continues to be a very good point, Steve, and a considerable area of risk for us at the moment in terms of our understanding of how that might be managed. I was on a national call yesterday where there's an indication nationally they will be feeding back to us soon, but we still don't know what the current position will be on that so we can plan more clearly beyond this month in terms of that impact. I think we should do more with our Southwest ICBs to pass that message back up the line and in a consistent way. I know other ICBs have just written or about to write to ask for both clarity around national funding on EOF, but also for the strike position. So I would consider it's a helpful thing to do along with other ICBs.
Do you want to come in first?
Yeah, can I just comment first, Steve? So I think it's something that we should raise as part of our regional director meetings. I think it's helpful to note that the government have allocated £200 million for winter funding, but it's of course also really helpful to reflect that that is less than what is lost in the industrial action that we're having on a very regular basis. I think it's we should note that the link between those two is being made in the media coverage of the 200 million. So now probably is the time for us to write to express our concerns around ongoing viability.
Okay.
Yeah, I'm very, very grateful for that. And I know colleagues are working incredibly hard to represent that position, so certainly support that. And I know this is a finance discussion, but clearly industrial action has impacts in terms of reducing capacity for providers. So makes the efforts of all providers to recover our elective performance more challenging, and does have an impact on morale across our across all providers. And I would just hope that there is a forthcoming national resolution which is satisfactory, which allows us to move out of the kind of industrial action position that we're in. And clearly we're seeing an escalation coming forward with consultants and junior doctors taking aligned action in the next two actions as well.
So are we saying that you're going to draft a letter, or are you drafting it on behalf of everyone, or?
So I think I'd like to speak to Elizabeth to find out which is the best way of collective response for this. But I also want to link, because all the time in the back of my mind now is the risk and harm dimensions. So it isn't just that the waiting lists go out, it's people have more complex operations and the impact for them is worse. So the risk and harm dimension of the industrial action and the impact on waiting and our financial ability to provide safe and effective services during the winter has to form part of the letter that we write.
Very good. Okay, thank you very much. Are you happy for us to move on? Thank you very much. So let's move on to the integrated performance report. So we have Kate Maynard on the screen. Kate, would you like to take us through it? Because this is quite a leap forward in terms of our new formatting and a direction of travel.
Okay, thanks. And good morning, everyone. So just to note that this is not yet in our new format. That will be coming to the next board, which I presume will be October, but subject to that new cycle of rotation, I guess. It is absolutely in the process of being built. In fact, the first cut is coming through today, but then that will go through its cycle of execs and through the subcommittees and then back to board. So today we are in pretty much the old format, and we're covering, first of all, operational performance, then quality of care, and then the third section was finance, which I think Simon has probably covered already, but you may want to come in. So I'll cover operational performance first and then just hand over to Susan for the quality of care. And I just wanted to flag a couple of areas, and some of this we may already have covered in the conversations and discussions already this morning. But firstly on winter and urgent emergency care. So the report demonstrates that there have been some areas of improvement through the summer weeks, which is really good. However, the pressures that we have experienced over the last couple of weeks really demonstrate, I think, that the system is quite fragile, and we need some robust delivery of the winter plans. And those, of course, incorporate tier 1 actions, intermediate care, delivery plans, as well as the usual sort of winter measures. And we are in the process of getting these all agreed and getting these mobilised as soon as possible. There's more work to be done on the plans, and not least, I think this was mentioned earlier, really robust demand and what I would call the impact of all of the interventions modelling piece to demonstrate that those plans will deliver us a much better winter. And as Kate's been talking about, with that focus on the harm reduction, which we know winters can bring. So that work should all be concluded over the next couple of weeks, and we'll be bringing back a getting through winter report back to board in due course. On elective, so, and this is the focus on the 65-week objective, to have no waiters over 65 weeks by the end of March 2024. So excluding orthopaedics, RCHT are on trajectory to deliver that target. There are still challenges within that, but they are on track to do that. However, orthopaedics isn't on track, and without a reworked up plan, I think we've all agreed actually delivery against that standard is going to be extremely challenging. We've been working on this over the last couple of weeks and have reset plans. So the ICB and Trust colleagues have been working together on this. And we've got like those new plans with week by week trajectories that just been finalised, and the ICB will support the Trust in delivery of this. And of course we are in tier 2 at the moment, so we've got regional colleague support on this as well. Key elements of that refresh plan include some external clinical leadership, and this is support really for the clinical teams to embrace and implement quite a range of new ways of working, about how the theatres work, extended days, weekend working, booking rules. It also includes some insourcing at weekends and a big push, as I would describe it, on choice and use of mutual aid across the country. And we've identified already a number of providers that may be able to help us with that. So we're just working through that at the moment. Now that range of interventions, if successful, will narrow that gap. But that change needs to happen quite soon, and we're quite mindful of that. And to help with that, there's an OD piece is also being considered just to help move that along. So we'll continue to work closely with the RCH team to support delivery of this. And as I say, this is all part of the tier 2 process at the moment, and we'll report progress through to execs and through to the finance and commissioning committee as well each month, and it'll be through the IPR. And then finally, just from me on the cancer metrics, there have been several improvements seen. They're not really statistically significant yet, but improvements regardless. However, due to the focus that we've had on elective orthopaedics and the 65-week trajectory of the last few weeks, I haven't yet had a chance to really firm up those trajectories, but I will make sure that they're included in that next iteration of our performance report as that comes round through the next cycle. So if that's okay, that was all from me in the operational performance. I would just hand over to Susan for the quality of care.
Thank you, Kate. As Kate said, we've got a new look at the IPR, some information that we still need to work on in terms of quality and what we put in there. I think for pointing out, I'd just like to point out the work that's going on around the Clostridium difficile. I'm so used to saying it as a three-letter acronym. We've still got more work to do that because within Cornwall and the Isles of Scilly, we still have high numbers of C. diff. A lot of that work is taking place with care homes and with our prescribing groups because there's a close link between C. diff and prescription of antibiotics. So we still have work to do. We're just doing some work with region and national around the infection control strategy that's come out that will take us over the next 5 years. And working with our pharmacy group, particularly around the C. diff, is incredibly important for us. I think, as Kate said, a huge focus on where we are in terms of quality, safety and patient harm in relation to our plans for winter and being very, very focused. We know that we had presented a paper last time to board, or a couple of times before in fact, around excess mortality rates. Really important that we coordinate all of our intelligence through our system coordination centre, and the actions that we take as part of being tier 1 for urgent and emergency. We're triangulating that with our mortality and our morbidity. That's to say people who have died, but people who have come to harm as well, so that we can prevent this and get further upstream. We have already covered Lucy Letby. We are doing our own self-assessment across Cornwall and the Isles of Scilly. As I said, we've done it for the main providers. We do need to take that wider. And we are working with regional colleagues as well around particularly the governance. What we don't want to do is overload the governance and make it so difficult for people to report, and how we listen not only to our staff but to the people that we care for and their families, incredibly important. So the work around the Lucy Letby case, and it goes wider than, of course, babies and children. This is about all of our population, and we need to be mindful of that, which is why the winter plans are so important in how we frame winter. We talk about winter plans, but actually what we should be talking about are plans that avoid risk, harm, and ultimately patient deaths. I'm happy to take any questions, Chair, as always, from the quality, but I think the focus for us really has been around morbidity and mortality. Just to say that our mortality system group has widened to include harm and morbidity, and in speaking to Region this week, they've decided to do the same, which is great.
Thank you. Sam.
Thanks, Susan. Really helpful to hear about the focus on excess mortality. And I think the data and the quantitative side is important, but I think the Letby case has highlighted that the qualitative information in terms of reporting is also important. And one of the issues that seems to be out there is whether these reports are being read at the right level. So could you give us assurance that at your level, in terms of the oversight that we're doing as the ICB, we're seeing that kind of qualitative reporting coming up, so that when we're looking at the quantitative data, we're also seeing if there is reporting coming from the front line?
It's a really good point, Sanj. Thank you. So yes, I mean, we do get very, we do like our SPC charts, but the narrative that goes alongside it is so important, and making sure that the narrative just doesn't describe the problem, but describes the solution as well. And I think that's been an eternal problem for any integrated performance report, particularly. We have done a review within the ICB, and I know Kim and Sarah James have been doing the same in providers, and we are working also, we've got to do this with primary care as well, around where that information flows and how it flows, and how you get that, what we called in the hospitals, ward to board, so that your board knows exactly what's going on throughout all of the organisations. And that's through that governance route, Sanj. And we are being really careful here not to overcomplicate this, because we need to know that as execs and non-execs, you've got clear sight. So the quality committees are incredibly important in this space, but also triangulating where we are with the morbidity. And I spoke to NHS England yesterday about those trusts that are in tier 1, whether it's elective care or UEC. How are we triangulating that information with the mortality and morbidity groups? Because if we're getting our actions right, then we should see a shift positively in mortality and morbidity. So I think we've got to challenge ourselves, both within our organisations but as a wider system, about how we make sure we're triangulating it. And we were one of the pilot sites for the patient safety information framework, and we are going back around the loop, because what that did was take us from single incidents, which you would be cited on to more trends. And what we need to do is test that against the Lucy Letby case, because what we need to be clear about is that it's single issues that often raise a red flag rather than waiting for that trend. So we are doing some stress testing of the PSERF, the patient safety information, to see if that would still pick up those extreme cases. But of course, we've got to be mindful, it's not just about Lucy Letby is an extreme case. It's all of the harm that happens on an everyday basis. So going back to your point, being clear about the function of our quality committees, not only the committee, but what feeds the committees. And that's the mapping that we've done through this paper, which I will be presenting through our own quality committee, and Kim and Sarah will be taking through their committees. We have still got some more work to do with primary care on that.
Kate, and then we're going to go Rachel and then Martin.
So I was just reflecting on what you've just said, Susan, around the PSERF, that I forget what the letters stand for, but you did PhD safety incident framework, reporting framework. So one of the things that happened with that was commissioners and providers will get individual instances coming across their desks. So without having any real knowledge of the service, you would notice clustering of things, not even knowing why that might happen. And as a helpful line of defence, that's really useful, because you can ask questions, and curiosity, as we're hearing now, is a very powerful defence against harm. So I would be really interested to see what the review of PSERF says. And I do just wonder whether we should go back to individual incident monitoring, just so we get the richness of the data.
Okay, we'll come back to that. Rachel?
Yeah, thank you, Chair. I suppose just for me, really positive to see some improvements around UEC, mindful that there's probably more work to do around the 65-week waits. It doesn't look like the trajectory is going down as fast as some of the others. So I suppose it's just not to lose sight of that bulge that's coming through. Really important to maintain that momentum. I suppose also quite helpful to reflect on the out of hospital community-based capacity, because that's going to be critical going through winter. And I'm again conscious that at some point it would be good to have a bit more of a focused discussion around the community bed capacity and length of stay, which again just appears to be a little bit stuck in terms of that reduction and assurance around a focus on the out of hospital as much. And I suppose finally, because mental health is in the indicator that's part of the soft framework, I suppose it's just an assurance around a real drive to address the talking therapies. We've been talking about it in our mental health programme board. I'm the SRO for mental health in the region as well, and it's a must do at this stage. So I can't stress strongly enough that we need to kind of get assurance that we can reach that target. Thank you.
Do you want to pick that up? Yeah.
So from a 65-week and a UEC perspective, we are working very closely around the national oversight arrangements, and our collective endeavour on the patch is high to make sure that we do what's right for our people and move ourselves into a much better position. In terms of mental health, we know that we have some significant issues with mental health and with access, and talking therapies is high on our list of things that we need to sort quickly, but we need to reflect that some of the way we do that may not necessarily be through our mainstream NHS providers. It may be through our providers across our communities, and the advantage of that is they may well be able to get to people and to offer services that we might struggle with. So instead of seeing it as a difficult thing, we should embrace it as a positive action.
Thank you. Martin?
Thanks, John. Might be slightly out of sequence, but I was following up the point around harm, really, which we talked about, I suppose, the data-led approach and also the escalation approach. But I just wonder if we've done enough to understand the sort of cultural approach of people feeling safe to raise concerns. And I know there are, for example, questions in the National Staff Survey that give us some indication of, within a particular organisation or service, how safe staff feel to raise concerns when they might feel the need. And I guess that part perhaps is something that comes through the workforce committee rather than the quality committee. I don't know, just to make sure we have that third angle, if you like, of assurance coming up somewhere.
Susan, did you want to respond to that?
I think it's a really good point. One of the things that we've done, Martin, is we're going to join together with CFT and RCHT. There's a Freedom to Speak Up month, and I think we do need to get underneath some of that psychological safety. I think we talk about processes and we feel safe by having a process of freedom to speak up, but it's actually those people that don't trust them, and how do we get that culture? So I think the opportunity for October for us as a system is to start getting underneath some of that culture. But I would agree it would be helpful for that to come through the Workforce Committee as well.
Steve?
Just briefly to follow up on the urgent and emergency care comments, we clearly still have a long way to go. Nevertheless, it is positive to see some of those key indicators starting to improve. The 12-hour trolley weight performance needs to reduce significantly, but it has nevertheless made a significant improvement over the last month. And also, there's a number of stroke indicators which I think absolutely reflect system-wide actions and system-wide working. So we see a trend over a number of months now for an improved position on stroke patients spending at least 90% of their time on the stroke ward. We see expected performance for swallow screen, and even in the stroke indicators that we're not delivering on, such as the percentage of stroke admission within 4 hours, whilst that's not at the required level, it is improving. So those stroke measures are only enabled through system-wide working, and I do hope those improvements continue.
Okay. Okay, colleagues. So something I picked up, which I wanted to comment on also, just for the wider context, is Susan, you read about the committees that we've got. Now, each of the committee chairs in the Integrated Care Board, you are in the process of completing, I hope, your reviews of your first year and your reflections as to how you might want to learn from what has gone on in your own committee and think about what you might do differently going forward, or more of the same if it's actually been working. I would ask Kate, along with Kate and Susan and other colleagues, that the work that I was getting really interested in terms of the next suite of IPR reports and metrics and that kind of thing will be used as this journey between going from the executive group through into committees and coming into the board is well structured as you go through that. So I would invite you to think about which elements of your new IPR are going to which elements of which committee, and to make sure each of them are getting assurance on that. So the challenge can be done in the committees.
Absolutely.
Rather than spend too much of our time doing it here. And I guess, Susan, one of the things that I just want some assurance on when it comes to looking at the helicopter view of this, because we've all got lessons to learn from the Lucy Letby thing, but one of the things that I'm picking up is data is data, depending on the lens that you look through it at. And sometimes I just want to ask the question, are we looking through the right lens of data to be able to know on certain things like that, would we have been cited? Are we cited? So when you come through with your new IPR report, it's just making sure you help us as non-execs and the board, assuring us that clinically we're looking at the right lenses, in the right time frames, with the right perspectives. Mary?
Thank you, John. It's a slightly different point, and I'm just thinking aloud, really, but I was wondering whether there is any way in the Integrated Performance Report of also reflecting public health initiatives so that we can look at the initiatives against some of the results, because I think that would be a helpful way of being integrated in what the county is doing, social care, but public health in particular, as to the effect on... So listening and reading the data on stroke, I know there are a lot of initiatives in the community around healthy living and so on, but it might not be possible to put those alongside each other. It'd be interesting if we could.
Okay.
So you'll all know that I get really frustrated about talking about strokes and stroke outcomes when we could be preventing them through monitoring hypertension. So the Know Your Numbers campaign kicked off at, I think it was the Cornish Pirates last Thursday or Friday. So within 6 months, we can stop people having life-altering, catastrophic events in their personal and family lives. So I think that point's really well made, and maybe we should pick a number of high-impact public health interventions that we're working together across the county and have them at the front or the back end of our IPR. I'll pick that up with Rachel.
Thank you.
Yeah.
Thank you, Chair. One of the areas over the past 20 years in Cornwall that the voluntary sector has had a huge impact around following the Budoc scandal in 2006, was in the provision of care and support for people with learning disability and autism in their own homes, which led to, under the Transforming Care programme, of Cornwall being the lowest emitter of people with learning disabilities and autism to hospital. Now, whilst the system priority is titled Mental Health, Learning Disability and Autism, there is actually no reference to learning disability or autism within it, and no metrics against which we're being measured. And appreciate that might be an omission for all sorts of different reasons, but I'm certain that there are some national requirements around learning disabilities and autism, you know, in addition to how we support people's access to whether that's acute care or GP care, etc. So just make that point.
Okay, thank you very much.
Can I pick that point up?
Yeah.
So I'm just conscious if Debbie was here, representing the mental health, learning disability and autism sector, she would be absolutely agreeing with what you're saying. So in her absence, I'll do it for her. We know that there are long waiting lists for autism assessment in our county. And we also know that we struggle to have crisis facilities for people with a learning disability who may not need a hospital bed, but they certainly need a little bit more in the community, along with those people with complex autism. So it is something that we're aware of, but you're quite right. We are not transparently monitoring, we're not transparently showing that we're aware of it, and we will pick that up.
Okay, so I'm just concluding this item now. So, of course, we've talked about 2 of the 3 parts of the store in some ways in terms of quality and money. One of the things that we'll be doing in our bi-monthly deep dives into this, the new IPR, of course, will be workforce. So Patrick, is there something that you want to just give us a flavour on looking forward? Less about what's in the pack today, but what's exciting you about what's coming forward and how we might look at a new way?
I was going to highlight, Chair, that in the development of the new IPR, we have a suite of workforce measures that we want to be reporting on that would include, amongst other things, the soft measures that are very prescribed relating to agency spend, which has come up on different items today, and a collation of other kind of key workforce metrics within our current models relating to absence, turnover, those kind of core things that you'd expect to see. So those have been itemised and are in development for the new IPR format.
Very good. And again, I'm just going to reach out to the executive group, and you will increasingly look at the journey of how you're taking that through the committees before they come here. I would encourage you to think about the diaries of that. If you need, as chairs, to reorganise your dates to fit in, this is the moment to think again with the new sequencing of what we're doing. Okay, are people happy with that? So, Kate, on the screen, in terms of the recommendations, I think bearing in mind this is sort of the last of the old format, I think what it's best to do in terms of the recommendations is to note and have had a conversation around it and look forward to the next pack.
Yeah.
Is that fair, Kate, on the screen?
Yes, that sounds great. Thank you.
So, by sheer happenstance, we're on schedule. So we've now got a short window of time to go through committee chair, partner, member updates. So I think possibly the best way to do this is ask by exception. So as I go round, just in terms of the table, is there anything, Steve, that you would like to share?
Just very briefly to comment, this is a newly formatted report based on some feedback that we've had from previous ICB board meetings. So it's trying to present some of the strategic headlines, particularly from Cornwall Partnerships, NHS Foundation Trust, the Ambulance Service, University Hospital Plymouth and Royal Cornwall Hospital. So any feedback, either now or very happy to take that feedback out of session to just get a view whether this helps going forward or whether further refinements would be useful.
Any comments back for Steve? So the only thing I did call you and say, I think it was a major step forward. Thank you ever so much for that. On reflection, the one area that might be helpful is the 111 service, but I thought it was a excellent step forward. So thank you for that. Tan, you want to add yours?
Very briefly, just to draw your attention to my additional chair's comment in workforce, which is that the Workforce Committee cannot yet give assurance that the processes in place will secure the reduction requested in agency spend cap by NHSE. We're going to review that at Workforce Committee at the end of the month, and we'll report back to October board. And also just to give you assurance that we will look at the Speaking Up campaign through Workforce Committee on the 28th.
Thank you. Martin?
Nothing to add to the rest of it.
No, thank you. Sanj? Carol? Anything?
Nothing further to add, John.
And as you're here on behalf of Debbie, AD, is there anything you want to add from a mental health perspective?
Nothing more to add, sorry.
Expecting anything, but
Prepared for that bit, thanks.
lovely. Anything I've missed, anyone? Any challenges to anybody else? If not, thank you for that. So let's go back to the agenda. So we now have the questions from the public relating to the agenda. Now, we did have 2 questions that came in that I think we've dealt with, but Karen, can I pass over to you for those? And I think there's a third one, but if you could deal with the questions from the public, I'd be grateful.
Thank you, Chair. Yes, so there were 2 questions that came in our July board. One was from Mr John Forsyth, and then the other one was from Mr Nigel Mawson. So they have been resolved and answers have been given to the gentleman and have been published on our website. We have had a question from Joan Heaton. And Kate, can I pass to you, please, because I understand you have the response.
Yep, thank you very much. So the question was, Cornwall and Isles of Scilly patients are often directed to out-of-area providers with capacity. How is essential medical information shared, and how is follow-up on discharge and aftercare organised in Cornwall and the Isles of Scilly when patients are treated out of county? So the response is Cornwall and Isles of Scilly patients are directed to out-of-area providers in line with national policy regarding choice. This means that, firstly, a GP will refer a patient using the electronic referral system, which means that all relevant medical information will be shared with the receiving provider as part of the referral. And secondly, if a patient has waited on an in-county list and is being transferred due to waiting times or requests an alternative provider in line with the NHS constitution, an inter-provider transfer will occur. The current provider is obliged to send all relevant information to the new provider. In relation to follow-up and aftercare, this is usually delivered by the out-of-county provider unless their care has been formally transferred to a local provider, in which the out-of-county partner will undertake an inter-provider transfer will occur as above. And finally, by way of further assurance and information, the inter-provider transfer is important for continuity of care for the patient, but is also equally important to avoid any issues regarding false clock stops, which would skew the waiting list time for that individual patient. Thank you.
Carolyn?
Thank you, Chair. Thank you, Kate, for the response. Just a correction to the comment that I made before, and my apologies. The questions came from Mr John Forsyth and Mr Peter Levin, not Nigel Mawson, so I just want to make sure that that's correct. So my apologies.
Okay. And can I invite Kate to make an observation as well on this, please?
So your answer was really full, Kate. I think what would be helpful to just add into it is that people only go to out-of-area providers if the provider is able to deal with the needs that the patient has. So less complex patients would be the ones that out-of-area providers are more likely to take. So when it comes to follow-up, if somebody's had a complex procedure and requires ongoing follow-up, they would be far more likely to be dealt with inside Cornwall and the Isles of Scilly or within Devon. So I just think it's to provide a reassurance to people that if they do need ongoing care, it won't necessarily be from a provider that's a long way away from where they live.
Okay. Very good. So what I'm going to do now is, bearing in mind we have the AGM and there'll be a whole opportunity for questions and answers as we go through that session. I'm actually going to make a few closing remarks and then close this meeting if that's okay, and then we can be done. So that I think brings the end of that particular part of our day in terms of the public board meeting. I want to thank all the board members and the audience, both in the room and online, for attending. To enable us to be ready for the AGM, can I ask everyone here, please resist the temptation to chat. These tables need to move, so please, with due haste, pack up and go somewhere else so the team can come in and do that. I'd be very grateful.
It's like being at a wedding.
Yes, it is. It is. Yeah. I'm going to do the drunk speech later on. Can I ask you, please, as an AGM, we start sharp at 12:15. So please be back in the room. And as a group of execs and non-execs, can I invite you to sit on different tables? We may have 100+ people. I think it would be nice for you to actually be part of the wider team. And then please, like I say, come back on time. Anything I've missed?
Yes, there's one other thing. There's one other thing, Chair, if I can ask people in their lunch break to please go and have a look at the stalls that are out and around. Your packed lunches will be set separately so that you can kind of receive those. But if you go to the stalls out and around, you will receive a raffle ticket, which John will have the pleasure of pulling for a surprise a bit later on in the day. So please do make sure that you go and visit them and you collect your raffle tickets.
Pace yourself, though. Lunch isn't until much later, though. Okay. So shall we draw a veil over this session? Lovely. Thank you very much, everyone.
Thank you.